Good afternoon. This is no, good morning, actually. This is Dr. John Bennett, broadcasting from Miami. This is in a continuing series of the online conference for the ACNS, the Asian Congress of Neurological Surgeons, headed by AIIMS. Today we have the honor of having Deepak Gupta, MD, a neurosurgeon from India, who's made the special effort while in Venice to communicate with us, and we really appreciate that. Let me first introduce the guest. We have Ramesh Nair, and have him say hello. Hello, Ramesh.
Hello, hi Deepak. It's nice to meet you here. I'm a skull-based and neurovascular surgeon in London, working at the Imperial Healthcare Trust, which is part of the Imperial University. I work at Charing Cross Hospital, which is one of the main hospitals in London. I've been here for more than 10 years now.
Nice to meet you here.
Very good. Okay, Deepak, it's all yours.
All right, thank you very much. And first of all, let me congratulate AIIMS and let me thank the entire team of ACNS for giving us this platform. It's a very unique opportunity and unique means to interact with the people who are not actually sitting in front of you, but it's almost like a virtual world, I would say. So thank you very much for the opportunity.
You're welcome.
So should I go ahead with my presentation?
Okay, sure. Okay, let me make sure. Let me share it here to make sure you see it. Okay.
Can you just make it bigger?
Okay, can you see it okay?
I see it well, but the slides are very small. But if you make it bigger...
Okay, hold on. Let me see if I can...
Yeah, that's fine.
Okay.
Yeah. Should I go ahead?
Yes, please.
Well, okay. So in the next few minutes, I'll be talking about my experience with hypothermia in severe traumatic brain injury or the head injuries. I'm presently working as additional professor of neurosurgery at All India Institute of Medical Sciences, New Delhi, and is associated with Jayaprakash Narayan Trauma Center. I also hold the status of principal investigator from India for the recently concluded Eurotherm 3235 trial, with the results of which have already been published in New England Journal of Medicine. I don't have any disclosures. The next slide, please. Well, hypothermia, I would say, is as controversial as most exciting things in life are. For the beginners who do not know much about hypothermia, well, it basically consists of lowering of the deliberate of the body temperature. It can be used either as a prophylactic means, wherein we call it as a protection use of hypothermia, or it can also be used as a therapeutic modality for control of brain intracranial pressure. By default, conventionally, we are using a temperature of 32 to 35 degrees Celsius, which is actually a mild hypothermia, I would say. 32 is in the moderate hypothermia range. And the initiation, duration, speed, and means of cooling actually varies in different cities and by different centers. Next. Well, sometime back, somebody said this thing for me. One of the ex-president of Neurotrauma Society of India said this thing for me. You can love him or hate him, but you cannot ignore him. And I think I feel the same about hypothermia. Hypothermia is in clinical practice for last, I would say, many decades. In fact, many centuries. If you go back to the history of papyrus and insects. However, it is something which is very controversial. There have been hundreds of papers talking in favor for it and hundreds of papers talking against it. Let's see where I take you in my present journey in the next few minutes. Next. All right, this is purely historical interest, and as you can see, if you go back to the history of 450 BC, people have been using using the snows to improve the survival for packing the wounds, and it has been used in the battlefield by various surgeons at that time. Next. Next slide. Well, the mechanism of action of hypothermia is pretty simple and straightforward. It basically acts as a cerebral protection, and we all know that as and when the more and more of neuroprotection action of hypothermia we get, At the same time, the incidence of adverse side effects also increases with hypothermia. That is something which we need to be very, very careful about. And this is how it commonly acts. It acts by retarding the destructive intracellular enzymatic reactions. It acts by reduction of calcium influx, by decreasing the free radical generation, and, and so many other things. In the interest of time, I will not be talking much in detail about the various mechanisms. Next. Well, this slide is something which is very, very commonly used, and most of the neurosurgical residents all over the world, they know about Brain Trauma Foundation guidelines. And many of them actually do not read about Cochrane data review or the publications in the Lancet Neurology coming in different time frames. But what a neurosurgical resident or a neurotrauma intensivist commonly knows is about the BTF guidelines. And this is a message actually carried forward whether one particular modality of treatment is useful or not. So if you go back to the BTF guideline of the revised ones which came up in 2007, it says that there is a level 3 evidence, and yes, preliminary findings do indicate that there is a greater decrease in mortality risk when targeted temperature is maintained for more than 48 hours. However, the difference was not statistically significant. So there is a chance of improvement of using hypothermia. And you can see on this forest plot, the red line, if you see, it is favoring hypothermia. Next. Now, why we are using hypothermia? Well, the major people who have got the maximum benefit in hypothermia are the cardiologists, I would say. There have been enough publications coming up on the efficacy and usefulness of hypothermia in out of hospital cardiac arrest, and the literature is replete with many such publications. So hypothermia can have very significant effect on various patient populations, acting as a powerful societal protector. Next. And in the kids, it has been seen that the children with the neonatal ischemic encephalopathy, the hypothermia has been shown to have significant benefit based on the Cochrane systemic reviews. Next. We must understand that the problem is all the hypothermic trials which are actually available. If you go back and read the animal experiments, most of the animal experiments so far have shown very, very useful benefit of hypothermia. However, somehow we have not been able to translate it to the clinical practice. So now it is basically time for us to take the bench to bedside and back to the bench in order to move the field forward. That is we really have to understand in case we want to take the hypothermia further. Next. Now, these are I mean, this is a very busy slide, but you can see the mechanism by which hypothermia actually acts. Basically, acts at different phases: the acute phase, subacute phase, and the chronic phase. It basically the most important role, if I am to summarize this busy slide, I would say it decreases or mitigates the effect of reperfusion injury. That is something which we need to be very, very careful about. Next.
Okay, I'm sorry, ischemia and trauma. Okay.
Yeah. Okay. So for those who have not been giving hypothermia on a regular basis, and for the young audience in this gathering, hypothermia basically can be induced either by the peripheral cooling or by the core cooling. The peripheral cooling is usually by using air or the water-cooling blankets. In fact, most of the trials which have been published in the literature, and including the European trial, we use the air surface cooling blankets for cooling our patients. People have also used ice packs, cool caps, helmets, specially designed beds, and water alcohol sprays and sponge baths for cooling the patients. Very recently, especially in the ongoing HOPE trial, people are using the intravascular catheters. I'll come to that how it is done. And for the core cooling, we have to use conventionally ice cold saline at a temperature of 4 degrees Celsius at a rate of 25 to 30 ml per kg of body weight. Then we also have to resort to some antipyretic drugs, esophageal cooling device, and in fact, direct brain cooling is also been advocated by a certain group of people for cooling the patient. Now, the issue which you need to remember is most of the hypothermia trials they have been based on one hypothesis. Earlier, we could the benefits. somehow most of the results of the NEBIS trial 1 and 2 they actually failed significantly, primarily because they were not able to cool the patients early, and that is why the presently ongoing HOPE trial people are actually using the intravascular catheters, because when you use the intravascular catheters you are able to achieve the target temperatures much earlier. I would say within a period of 2 to 3 hours you can reach a target of 32 to 34 degrees Celsius, which is actually what we want. Next. All right, so this is how a patient actually looks like in an ICU setup. And the hypothermia, I would recommend it is to be done only in high volume centers which have got a very strong backup of a neurointensivist team with you. You need to have invasive blood pressure monitoring, central venous pressure lines, rectal and esophageal temperature probes. The ICP monitoring is a must for the patients undergoing hypothermic therapies. Patients need to have a very intensive neuronursing monitoring by the hourly urine output, blood sugar charting, LFT, KFTs, coagulation profile, lab assessments, temperature corrected ABGs, and the access to that doing the CT scans. We in Jayaprakash Narayan Apex Trauma Center are lucky enough to be blessed with state-of-the-art mobile CT scan inside the ICU itself. And in case you have got access to all these facilities, you are able to do these investigations on your own. Next. All right, so basically the technique is pretty simple and straightforward. It basically consists of cooling the patients by using the ice cold IV saline at a rate of approximately 1.5 liter of ice cold saline is given to the patient over 1 hour period, and subsequently the temperature is maintained by surface cooling blankets. All these patients naturally they have to undergo elective intubation, and they are sedated with midazolam and fentanyl. They are on full ventilatory support. The most important thing is to be remembered, everything changes completely when the patient is on hypothermia, because the metabolism of all the drugs changes completely. And so you need to have a neurointensivist who needs to adjust the ventilator settings when the patient is cool from a temperature of 37 degrees Celsius to 35 and lower down. Also, it is important to understand and know that when these patients get some infection, which does occur in some of these patients, there's an increased load on the machine, on the mechanical ventilator, and that needs to be picked up, and the ventilator setting needs to be adjusted accordingly. The monitoring, as I've already conveyed, they need to have a series of non-invasive and invasive monitoring when the patients are undergoing hypothermia therapy. The other thing which is very important is how to rewarm the patient. The rewarming rates have to be very slow, to the tune of 0.025 degrees Celsius every hour. It has been seen, if you rewarm your patients early, the incidence of side effects, complications are very high, and in fact there is episodes of rebound intracranial hypertension also are very high. So that needs to be taken care of. Second thing which we need to understand and know, that hypothermia is something which is not free of problems. It is something which is to be given only in advanced ICU setups, as a lot of these patients, they do have episodes of shivering, which can actually mitigate the effect of hypothermia. There is an increased incidence of pneumonia, coagulopathies in patients who are being cooled. So all those things have to be very delicately and thoroughly managed by a team of neurosurgeons and neurointensivists together. Next. So basically you need to control, these patients usually have got insulin resistance, so they have got incidence of hyperglycemia, hypokalemia when the patients are being cooled, and the reverse occurs when the patients are rewarmed. So all these things have to be really taken care of. Next. Now, so we in the Eurotherm trial, which was recently completed, I'll come to the Eurotherm trial in the last part of my slides. So at All India Institute of Medical Sciences, we had 34 patients out of 375. Approximately 10% of the patients of the Eurotherm trial were contributed by our center, and interestingly, our results were very satisfactory. In fact, the hypothermic patients, none of these patients had got any episode of coagulopathies or pneumonia in our series, and the chances of conversion of DC was also not significantly higher in the patients undergoing hypothermic therapy. Next. And we had an excellent graded response of fall in the ICP noted with the hypothermia. In fact, this is what is there in the literature also. Hypothermia per se I mean, there is no doubt that the gradient control or the reduction of the intracranial pressure is beautifully managed with the hypothermia. There is no doubt about that. However, controversy shrouds whether the usefulness of hypothermia in its value as a neuroprotectant. Next. In fact, if you see the ICU stay of these patients when they were receiving hypothermia was lessened. The total hospital stay was lessened. The number of episodes of ICP, intracranial hypertension, were lessened in the hypothermic group as compared to the normothermic group. Next. And so in fact this paper was one of the top 5 award paper in the International Neurotrauma Congress in the Budapest in 2014, and the average time to attain hypothermia in our series was 2.6 hours. Next. Now, we must understand most of the hypothermia trials they are jinxed with early stoppage for futility, because if you talk about the Cool Kids trial for the children, if you talk about National Acute Brain Injury Study 1 and then 2, if you talk about in fact the Eurotron trial also, all these trials have been stopped early for lack of futility. So is there any hope for future? Next. If you talk about the Cool Kids study, this was carried out by David Edelson by the Phoenix group. It was again terminated because there was no significant difference between the hypothermic and the normothermic group found at 3 months after the injury. There were 35 cases, 350 cases were randomized for this study from 12 centers. However, only I would say 77 patients could be enrolled in the study, and when the futility analysis was done, the results were not found to be satisfactory, and so this trial was actually stopped prematurely. Next. So this shows what are the biochemical and metabolic changes taking place in the patients when they are undergoing or when they are being cooled. People have got very high incidence of hyperglycemia and insulin resistance, metabolic acidosis, shiverings, and disturbances of electrolyte balance during the cooling phase, and subsequently the reverse occurring in the rewarming phase. Next. Now, what are the red herrings for hypothermia? Most of the hypothermia trials, I would say, is primarily because they have failed. The people have been giving insufficient regard for the side effects. It causes the partial negation of protective benefit of the hypothermia. So, in case you are not able to manage the side effect of hypothermia, which is actually one of the manifestations of hypothermia, I would say, naturally you will have more complications, and this has actually led to the poorer outcome in the patients of hypothermia in the trials which have been concluded. So in case you are able to really manage those side effects well, and by a careful planning and a good neurointensive control, I'm sure the outcome of the hypothermic patients can be improvised. Next. This is the first trial on hypothermia, I would say, was published in New England Journal of Medicine. The Clifton, in fact, has done the National Acute Brain Injury Study Part 1 and Part 2 was subsequently done in 2007. And again, the first trial was stopped for lack of futility and showed no improvement with the hypothermia. However, from the results, they did conclude that probably very early cooling may improve the neuroprotectant value of hypothermia. Unfortunately, there were more events of critical hypertension in hypothermic group. Next. Now, the game changers in hypothermia, I would say, are the Chinese group. Professor Jiao Jiang. I mean, they have a very different policy as compared to the rest of the world. Professor Jiang, actually, they feel, and in fact, they have been giving hypothermia routinely to their patients. They found that patients who have been cooled very early and very prolonged for more than 5 days, the outcome of the long-term cooling is more efficacious as compared to the 2 days of short-term cooling. And you can see the favorable outcome in the patients who were cooled for the longer period were significantly higher as compared to the patients who were cooled for a lesser duration of time. So the Chinese group of people are very much strongly propagating that you have to cool the patients for a longer duration of time. And actually this is scientifically also explainable, because we must understand in the initial days, in the very early phase, the neuroprotectant value of the hypothermia actually depends on how early you cool the patient, because the neuronal cell death starts taking place very early after head injury. However, we have seen that patients have got rebound intracranial hypertension taking place after 48 hours, 72 hours. And it is during this phase, if you are cooling your patients even after 2 days or 3 days, you can control those episodes of intracranial hypertension. So begin early and continue long. That is the message from this group of people. Next. So this is the post-hoc analysis which Clifton carried out in 2011 after the two trials, and Andrew Moss very nicely concluded, we do not think that the present study puts an end to hypothermia and traumatic brain injury. Rather, it should stimulate further studies in which depth and duration of hypothermia as a therapeutic strategy should be better targeted to the individual needs of every patient. And I think what Andrew Moss says is pretty correct. Next. So in fact, when the post-hoc analysis of NABIS 1 and NABIS 2 was carried out, it was concluded that you have to identify certain subsets of patients. I would say the patients of acute subdural hematoma, which have got very high incidence of reperfusion injuries. These are the group of patients who should be targeted. You should be cooling these patients very early. These are in fact the messages which came up from when the NABIS 1 and NABIS 2 trials were critically analyzed, and that is what that has paved the way for HOPS trial, which is actually presently going on in Pittsburgh. Next. And Walter Dietrich has from the Miami has got immense experience on the hypothermia, especially the animal experiments, and somehow he also feels that now it is time to go back to the benchside research, because somehow we failed in the bedside when we tried to translate the results of animal experiments to the human studies, but now it is time to go back to the benchside to see where actually we went wrong to further improve the outcome in the hypothermic patients. Next. And in fact, if you look at the Cochrane data review also, Cochrane data review carried out in 2009, it does recommend hypothermia to be used in the context of high quality randomized controlled trial with good allocation treatment. That is something which is very, very important. It is not, I don't advocate, I don't canvas, and I don't advise that hypothermia to be used at each and every center. Only in the centers who have been doing hypothermia on a regular basis, who have got good backup, good support, good intensive care, only those centers it should be done, and there too as a part of high quality randomized controlled trial as of today. Next. And this is a few meta-analyses which have been published. I'll skip that in the interest of time. Next. And subsequently, can we come to the next slide? This is another interesting paper. In fact, I would say this goes more in benefit of the Asian population. It was published in Brain Injury, and when further subset analysis of meta-analysis was carried out, it was found that moderate hypothermia may be effective in reducing death and unfavorable clinical neurological outcomes, and this finding is not statistically significant except for decreasing the mortality in Asian patients. So this actually people have gone to the extent of analyzing and reanalyzing in depth where they went wrong, and when subsequent analysis have been done, it has been noted that in Asian group of patients the mortality rate is lower when in the moderate hypothermia group. And why it is so? Next. People in various institutes have actually, this is an unpublished work from one of my friend in Copenhagen, and she has actually carried out the genetic level of work in these patients who have been cooled with the hypothermia, and there have been some genetic abnormalities and upregulation of the genes taking place in when the patients are cooled. So there are some genetic changes taking place in different subsets, accounting for different outcome of the hypothermia in different population group, I would say. Next. Now it is basically time to relook into the hypothermia targets. We have to understand that the Glasgow Coma Scale has got nothing to do with the disease itself. I'm sure, I mean, the patient of contusion, the patient of subdural hematoma, diffuse axonal injury, extradural hematoma, they're completely different altogether. And we should not be basing our treatment purely on the GCS. It has got nothing to do with the pathophysiology of the disease. Come on. So if you really see, the incidence of ischemic reperfusion injuries are the highest in patients of acute subdural hematomas, and these are the patients I personally feel they should be the potential targets in the future hypothermic trials. Next. In fact, it has also been seen that hypothermia, apart from having an influence on ischemic reperfusion injury mitigation, it also helps in decreasing the CSD or the cortical spreading depolation. Probably there is a class 5 evidence, I would say, that therapeutic hypothermia reduces post-traumatic epilepsy. Next. Now, as of today, there are two trials going on in the international literature. One is by the Jamie Cooper from the Australia. They are doing a prophylactic hypothermia therapy, in which actually All Institute of Medical Sciences is a part of. Therein, they are cooling patients within 3 hours of injury, and that is the basic challenge. And the philosophy is again very clear. Begin at the earliest, because from the previous trials we have learned, unless and until we cool our patients at an ultra early period after the injury. In fact, the patients in the pre-hospital transport period, they have been cooled with this therapy. And so far, this trial is quite lucky, because it has not, the 50% data has already been carried out, and the trial has not been stopped for futility. Most of the previous trials, including the recently concluded Eurotham 30 to 35, has been stopped prematurely for lack of futility. However, the polar randomized control trial has finished its 50% landmark and is still going on. The beauty of this trial is that it does use something called as a deferred consent, because when the patients are sustaining injury early, we do not have any means to obtain consent. So because our intention is to treat the patient with a positive benefit, so we can cool the patient with the ice cold IV saline, waiting for the consent to be taken from the next of the kin of the patients. Let's see what are the results come out to be, because the results are not yet available, though the trial looks pretty promising as of today. Next. This is how the recruitment status as of now. Next. The next trial which is going on is the effect of early cooling in acute subdural hematoma, or the HOPES trial by David Okonkwo from the Pittsburgh group, and they are using a patient to cool patients with a Glasgow Coma scale of 5. Patients to be cool within 6 hours of injury, and the cooling has to be minimum to be maintained for more than 3 days. That is a basic thing in this trial, and the patients are cooled by the intravascular catheters. The idea is again very clear, that we want to cool the patient at the earliest possible. However, yes, there are some apprehensions and kind of raised eyebrows raised by the people, because uses of intravascular catheters to cool the patient, apart from it being very expensive, is not free of side effect and the complications. So that is something which is to be seen when other centers start to resort to it. Let's see what are the results of acute subdural hematoma trial come out to be. Next. Well, why we are talking about hypothermia in such a great depth, we have to understand that all over the world, let it be Australia, Europe, USA, and in the low middle income countries, India, Brazil, and other parts of the world, trauma remains a global epidemic. Back home in my nation, India, approximately 1 million people die of traumatic brain injury annually. In the world, approximately 10 million people die. And on a very serious note, we have to understand that the outcome and the surgical options management in the acute TBI, they're quite negligible, and not much has actually happened at the surgical front. The search on advanced multimodality monitoring and medical means to treatment is actually ongoing, and we really have to look for some means to improve the outcome. And I personally feel, despite the failures with many trials, hypothermia is one such means which does hold some promise to have give some benefit to our patients of traumatic brain injury. Next. So the facts about hypothermia which all we should know is that it is the first treatment with a proven efficacy for ischemic reperfusion injury, and it activates a protective mechanism or the progene activation. We have to understand that hypothermia does not cause hypertension if cold diuresis is managed. All these patients, because of vasopressin insensitivity resistance post cooling, there is an episode of cold diuresis which leads to loss of water from the body, which leads to hypertension. So in case you adequately and clearly manage your fluids by having a anticipation that this is what is going to happen to the patient, the episode of hypertension does not occur in hypothermia. It actually does not cause hypothermia, though people talk about the arrhythmias happening. It does not cause arrhythmia. In fact, I would say the mild and the moderate hypothermia actually treats arrhythmias. It is mild and the moderate hypothermia is safer than the deep, so we should be aiming for a temperature of 32 to 34 degrees Celsius. We have to understand the ventilator settings have to be very critically adjusted when the patients are being cooled. There have been episodes of increase in the infection rate and the pneumonia in patients of hypothermia, so they need to be managed accordingly by using selective digestive tract decontamination, erythromycin, daily cultures and antibiotic therapies in a very planned way when you are cooling these patients. Next. So you can see these are a couple of patients when the CT at admission and after 5 days when the patients have been managed by the hypothermic therapy, the cisterns have opened up and this patient actually went on to make a good recovery. Next. Well, as I said at the beginning itself, you need to have an advanced ICU setup while monitoring these patients and cooling these patients. Next. Yes, this is how the hypothermic machine, the Arctic or the Gamer machine for the surface cooling actually looks like. These are the various intravascular catheters which are used for cooling the patients. Next. Now, who should use hypothermia? Whether it should be used routinely or not? Well, we do have certain preliminary guidelines by Neurotrauma Society of India or the Indian Hereditary Guidelines, which actually mention that hypothermia is actually experimental and should not be instituted in the patients. However, I do have a different opinion, and I feel that hypothermia as of today should be used as a part of high quality randomized control trials in high volume centers with having a reasonably decent experience with the management of these patients. Next. And so these are the results of NEJM published Eurotherm 3235 trial. In fact, this trial has also been stopped, and in fact, we were actually looking. This trial will be a game changer and will tell us whether the hypothermia is to be used or hypothermia is not to be used. But needless to say, every trial or every study which has been carried out so far, they do have some flaws or some shortcomings in them, and Eurotherm trial was not an exception to it. In fact, the incidence of unfavorable outcome was slightly more in the patients of hypothermia group as compared to the patients in the control group, thereby putting a stop. Thereby, the conclusion from this study was therapeutic hypothermia plus standard care to reduce intracranial pressure did not result in outcomes better than those with standard care alone. Next. These are the group of patients. The most interesting thing about this Eurotherm, we have to understand that they were cooling their patients as longer as after 12 hours of injury. In fact, if you see this very carefully, over 176 cases were cooled more than 12 hours after the injury. Patients were included in the study up to 10 days post-trauma. Patients who had one or neither reacting pupillary response, they were more in the hypothermic group as compared to in the control group. Marshall's classification, there were more number of patients of diffuse axonal injury with a grade 1 to grade 3 in the hypothermic group as compared to the control group. And it has been shown that these are the group of patients which are unlikely to be benefited by the hypothermia. So probably there was something wrong in the group classification in this patient in the post-facto analysis. Next. However, the control of intracranial pressure and was very well managed. All these patients had a very good graded control of the intracranial pressure with the hypothermia. Next. This is the primary and the secondary outcomes in the hypothermia versus control. There was no benefit of hypothermia in the Eurotherm trial as compared to the normotherapy group with standard of care. Next. So my take on hypothermia in the present context, I would say, is hypothermia for severe traumatic brain injury works with correct patient selection. It is recommended only in tertiary care advanced trauma centers with high volume severe traumatic brain injury adult subjects being treated on a regular basis. It should be done as a part of high quality, well designed, super selective randomized controlled trial with controlled parameters for starting, maintaining and removing these patients. And the most important thing is that you have to know your tools. You should have a very good amount of experience with cooling of these patients to avoid and to manage complications of therapeutic hypothermia, which are actually preventable mostly. Next. Thank you very much. Thank you.
Okay, let me get my volume on here. Thank you very much, Dr. Gupta, and really thank you and Ann for making a special effort while you're in Venice under circumstances on the road, connecting on the road. Dr. Nair, are you still there? Hello, Dr. Nair? Well, yeah, I just want to make a remark. Of course, I don't have a lot of. I'm not a neurosurgeon. I just read about anecdotal stories that I'm sure you're aware of that happen. In
Michael
the U,
Schumacher.
yeah, in the U.S., mostly they occur in kids, and actually they weren't part of a study. These are kids that maybe fell into the water, cold water, while ice skating, and there'll be anecdotes of them surviving. Now, I don't know if it's characteristic or it's just rare instances. Do you have any remarks on that at all? No, I don't know if India has that kind of. Uh,
Well, you're right in saying it. We must understand that traumatic brain injury is a heterogeneous population.
mhm.
And unless and until you have got a huge data to back up, to substantiate the results, whatever the trials, the randomized control trial you will do, you will not get good results. We know about the story of Michael Schumacher, who was actually subjected to hypothermia. We know about the story of Anna Bergelen, a Swedish radiologist who survived. She had in fact 91 skiing race wins, and she survived hypothermia when she was buried in the snow for more than I think 3 days. He was paralyzed, and she came back to the normal life way back in 1999, and now she is a practicing radiologist in Sweden.
Okay.
And we do know about episodes of patients being. In fact, this is one of the means people use when they have exhausted all their resources, thereby saying that hypothermia does have some value. I mean, it just cannot be ignored. It has to continue in the practice, but only in a very guarded way, only at the advanced centers of care. The crux of hypothermia is that you have to begin very early as 3 hours or within 6 hours of injury, and you have to continue it at least for 4 to 5 days. The reason people are actually scared of continuing hypothermia for more than 48 hours or 72 hours is that the incidence of complication and the side effects like coagulopathy, pneumonia, infections, and electrolyte disturbances, it increases after 3 days. So people are more conservative to manage that. However, if you can foresight those complications by having a good backup support of neurointensivist with you, I'm sure the outcome with the hypothermia can be at least reduced significantly. This is my personal feeling. We have been giving hypothermia as a standard of care in any trauma center. I've also completed my study on hypothermic and studied the effect of hypothermia on the metabolism of the various anti-epileptic drugs. I've also correlated hypothermia with cerebral microdialysis, where we have documented that yes, the incidence of ischemic injury is less when the patients are cool by doing the lactate pyruvate ratio in my group of patients. So it cannot be completely ignored. However, I am not giving a message to the masses and the media that please cool all your patients. No, you have to cool a very selective subsets of patients. However, if you cannot cool your patients, the message I want to give to everybody is that at least maintain normal temperature. Hyperpyrexia is disastrous to the head injury patient. Either maintain a normal temperature, and if not, if you have got adequate backup and if you exhausted your tier 1 and tier 2 therapies, then of course hypothermia is there in your pocket. Why not use it?
Very good. Very good, Doc. Okay, well, I welcome you to present further studies if you have you're doing further studies in this and any topic that you wish to talk about on the channel of Neurosurgical TV, whether it be hypothermia or traumatic brain injury or whatever. And we appreciate the extra effort that you put in to connect with us while on the road.
Thank
So,
you very much. Thank you, John, and thank you very much once again. I'm truly honored to be a part of your team. Thank you
oh
very much.
yeah, we want the wizard to be part of it too.
Thank you. Bye-bye.
Okay. Thank you.
Bye.
Bye bye.